Hello. I feel like I'm kind of dark here. I'm Gail Lee, and I'm the president of the board for Aging Advantage. And we are doing this presentation. We're having a few minutes of issues becoming live this morning, but this is our next in our series of classes, and we're going to look at end of life and hospice issues today. So Aging Advantage is a nonprofit here in the St. Louis area, and these programs are being kind of funded through the City of St. Louis ARPA funds for city households that are experiencing a negative public health and economic impact due to COVID. But we provide a lot of services in the city for those 60 years old and older and people with disabilities and their families by helping them manage all kinds of aspects of their daily life. So in regards to the things that happen with COVID, a lot of people have social isolation, a lot of economic impacts. And so we then have to go in and help with care management and mental health support and different things with that. But today in our series, we've been talking about just how to plan and prepare going along the continuum. So now today we're looking at hospice and end of life. And we are doing this in conjunction, this whole series in conjunction with Eamon Gantner Capriano. And so Amanda Wilson, our attorney here, is going to talk about that for a minute.
Absolutely. So if you've been tuning in throughout the series, we've called it Preparing Your Legacy Roadmap to Planning, Protection, and Peace of Mind. So we're kind of taking you on this sort of holistic journey through aging, what that looks like, why planning is important, what kind of planning you need to be thinking about, and just sort of a lot of the realities that face individuals as they age in terms of care, what that looks like, what sort of care they want, and how sort of legal implications and social implications come together in this context. And so this is Eamon Gantner and Capriano. We are estate planning and elder law attorneys. We're members of the National Academy of Elder Law Attorneys and the American Academy of Estate Planning Attorneys, and we're accredited by the VA to handle veterans' claims. We dedicate our legal practice to estate planning, elder law, as well as postmortem work. So that's going to be probate and trust administration. My name's Amanda. I am an associate attorney here, and I sort of entirely stay in the elder law realm. And I work with Gail along with another licensed clinical social worker on our staff named Maggie. And we kind of tackle all of these problems that we're talking to you about in this series every day. So yeah, that's us.
So I'm going to introduce Lee Howard-Ginther. She works part-time on our staff at Aging Advantage, doing some behind-the-scenes things, but she has her master's in divinity, and she's board certified chaplain, and works with these issues every day. So she's going to do a lot of the talking today in regards to what she sees with the end of life in the hospice and some of the legalities of it. Amanda's going to chime in. So Lee happened to come, and she's going to be using my computer. So we'll both kind of be talking on that. But here, take it away, Lee.
So good morning. As she said, my name is Lee Howard-Ginther. I'm actually on the board for Aging Advantage as well, but my daytime job is at SSM as one of their hospice chaplains. With that being said, today's topic is about hospice and end-of-life care. I know the idea of hospice makes a lot of people nervous because they think of hospice and they think, I'm immediately going to die. Well, that's not always the case. So what we'll be talking about will go a little bit more in depth into what that whole realm is. It's a lot bigger than just hospice and end of life. And it actually starts with palliative care. So palliative care is the overall arching umbrella. Hospice falls underneath palliative care, but palliative care is offered in the hospital and at home as a way to help manage symptoms with a chronic and or terminal condition. So say you get a cancer diagnosis, or if you have something like MS, any of those kinds of things where it's terminal, chronic, well, and or chronic, it can be one or the other. And it's to go along with aggressive treatment. So again, hypothetically, say you get a cancer diagnosis and you're going through chemo and radiation, which can be very painful and very hard. How do you manage your treatment? They will help navigate aggressive care, offer pain management, but it will also allow you to go to the emergency room if you need some additional care. Palliative care is just a way to give you some additional support while you're navigating, struggling with whatever medical condition you're going through. With that comes this quote that I really like and it's from an article that a colleague and I have found. The title is called Amen and Challenging Conversations. So the whole article is talking about how doctors can have difficult conversations with patients. But the quote is, among patients with incurable colon or lung cancer, 2/3 think it is possible to be cured with chemotherapy and radiation. If end-of-life discussions are held with patients with lung cancer, only 27% of medical records have any documentation. Half of the time they occur with physicians other than the oncologists, and the average time at which they take place is 33 days before death. 2 months before death, half of all terminally ill patients with lung cancer have not had their physicians mention hospice or palliative care. Additionally, most oncologists prefer to bring up hospice, advanced directives, and so on when there is no other treatment options. So as a chaplain, we find this quite alarming all the time because I've also seen the benefits of palliative care and that overarching team, the support you get, as well as the pain management. And it helps you ease into the transition. Say you do have a long-term chronic condition that has now become terminal, transitioning into something like hospice. And again, it just adds extra support. Sometimes people get on programs like palliative care or hospice and they end up doing so well with the extra support. They end up graduating, they end up outliving any expectations because now they can manage their symptoms, they can get their treatment. So this statistic that only half of any terminally ill patients even know that it's an option is kind of surprising. And only 27% of it is documented in the medical charts. So as I'm presenting this to our audience, I hope that if you are in a situation where you have a chronic condition or cancer or anything of the like, that you speak up and ask questions about palliative care and how it may or may not be helpful to you. And as I bring up other points in this conversation about what are your goals of care, would you like to be more comfortable as you battle or struggle with these different conditions? What's important to you? Would you like to have pain management? Would you like to be able to travel? Would you like, those kinds of things? That's some of the things you need to consider when you're thinking about when you're planning potentially, right? It's all somewhat in a hypothetical sense when you're talking about planning end of life care or palliative or hospice when you may not even have a condition quite yet.
Right. I'll just say, Lee, that we see this all the time. People don't realize they can get palliative care, hospice care provided to them. And so they don't even realize that, it's an avenue to go down. And we have a lot of clients who have hospice or palliative care, usually hospice, who live a pretty long time, and normally you think of hospice as end of life. Yes, that's true. But I know, Jackie, one of the partners, she talks about a woman that we did some planning for who was on hospice for a little over 3 years. So you just, and why not receive that extra support if it's something that will make you more comfortable, if it provides an additional support role for you, because a lot of times you get different nurses who come in from hospice who are sort of taking care of a different aspect of your care. And almost all the clients I have ever spoken to who have been on hospice, it's a very helpful system for them. They like the care that they receive. They like, I don't know. I sort of think that hospice providers are a special kind of human, right? They deal in this realm all the time, and so they're very compassionate, and they're very, very good with sort of the family dynamics and just the human dynamics of what it means to be at or near the end of life. So
Well, and it's for palliative care and for hospice, it's one of the only things on any kind of insurance, whether it's private pay or Medicaid or Medicare, that's almost, I think palliative is like 80 to 90% covered completely by your insurance companies. And hospice is 100% covered. So a lot of people are like, oh, this sounds great, but I have to pay for it. Well, actually, most of the times, no, you don't even have co-pays. As long as it's anything relating to your terminal or chronic condition, right? Say like if I had Parkinson's disease and I have to take my daily vitamin D, well, they may not pay for my vitamin D, but they'll cover all my other stuff. So that's pretty great. And I always think of this too, because my grandfather, when he passed away, I kept advocating so hard to get him onto palliative care. Like, why is nobody talking to him about palliative? He kept having horrible back pain and horrible leg pain. So they kept signing him up for physical therapy and PT, which is great. Don't get me wrong. That's great support. But there was no conversation about palliative, and I kept asking, why is nobody talking? And then as he got closer to his end of life, and eventually they did make the decision to put him on hospice, it came to light that he was only getting palliative chemo. So he wasn't even getting chemo to cure the cancer. He was just getting chemo to treat the symptoms of the cancer, which is kind of why this quote from this article really stands out, because that's what he was getting. He was a terminally ill patient that was getting not curative radiation and therapy. He was getting symptom management. Well, if that's the treatment plan, is only symptom management, why was the conversation never had about palliative in the beginning? So that's something that I empower everybody to ask. If you suddenly get a new diagnosis and you're like, well, what about this? What, like these, it is something to think about, especially then when we do talk more about hospice care specifically. We're going to move on to the next slide there, man. Yep. So what is hospice care? Hospice care is under the palliative care umbrella, but it is more specialized for people that are typically at they have a life expectancy of 6 months or less. That being said, as Amanda shared, you can be on hospice for a long time. I had once when I was as a hospice chaplain, I did have a patient who was similar, who she was on it for like 4 or 5 years, but she just kept doing she was still terminally ill. Her condition it just wasn't worsening as fast as they were expecting. So she had that extra support. She kept getting her pain management. She was at home with her husband, and that's what she wanted to do. She wanted to die at home, and she just kept moving along, trucking along. But it's focused on comfort care. So at that point, when you've gotten this diagnosis and suddenly you're at the potentially last 6 months or less, and you're saying, you know what, fine, I don't want to go to the hospital anymore. I don't want to get any more aggressive treatments. I don't want to go back to the emergency room, none of that stuff. Hospice is potentially the right support system for you, because you will not be receiving any more. When you sign up for hospice, you say, I'm done with all of that. I will sign a DNR. a do not resuscitate, which I'll talk more about that later in the presentation. And it's a focus on comfort and about quality of life, what's left of it anyway. So we have, when I was working with hospice, we had a program for veterans specifically, that if they were in the last month or so, if they signed up for hospice, what's the last thing they want to do? We would try to make that happen. There's a lot of different things you could do for hospice. Unfortunately, the statistic is a lot of people do sign up too late. So they sign up and then they end up dying very shortly after. And I think that's why a lot of people have this negative misconception about hospice. Well, if I sign up for hospice, I'm going to die. Well, yes, but it may end up being a very beneficial thing. As Amanda said, you have the nurses that come in. You'll have a specialized hospice doctor help manage your care. You'll have nursing assistants come in and help give specialized care regarding showers and all those kinds of things. You may even get a music therapist. I know of one hospice company that partners with massage therapists. So you can get all kinds of cool benefits on hospice. And as I mentioned earlier, it is one of the only things 100% covered by private insurance, Medicare, and Medicaid. So that's kind of exciting. You don't have to worry about it payment-wise. Now, there's different kinds of hospice as well.
Sure. No, keep going. I didn't mean to interrupt.
Oh, no. If you wanted to chime in, you're more than welcome.
I was just going to say I think a lot of people think too that hospice is you have to be in the hospital or in a facility, something like that. Hospice will come to your house. My grandpa was on hospice in his home, and his nurse was so funny. He had a real issue. He had prostate cancer, terminal. And so it created a lot of pressure for him. And so he was really invested in enemas. He thought it would solve the problem. So he was giving himself enemas like sometimes multiple times a day. And so his hospice nurse, though, I mean, she would call him, she would come by. I think she came by once a week, maybe once every other week. But she was able to have some of those really difficult conversations with him too, because he would not listen to any of us about, you're not doing yourself any favors here. Let's slow it down a little with the, self-treatment stuff. But they just had a really great relationship, and she went above and beyond to make him comfortable and, to say, okay, so you're feeling this pressure. Let's think of some things that we can do that will help it, and then maybe ease off of, some other things. But, so I wanted to pop in with that story, but sorry.
Well, no, I mean, it's a very real example of how hospice can help. And there is and if you go to the next slide, I will talk about, there is a version of hospice in the hospitals, and that is inpatient hospice. What that means is you are so medically unstable that you cannot go to where you live, whether it's a nursing home, an apartment, a facility. Like there's even hospice homes, specialized treatment facilities that only specialize in hospice care. There's two here in St. Louis, the DeGreff House in South County, and Evelyn's House. It's in like the city, right? Evelyn's House? No, I don't know.
I think it's up in like
BJC affiliated
area.
Oh, it's in West County. I'm sorry. I think BJC, and I'm thinking big BJC hospital, but no, it's in West County. Evelyn's House is really unique too, because they actually have a pediatric hospice wing. Most people, when they think of hospice or end of life, they're thinking of, somebody in their 80s, 90s, towards the end of their life. But sometimes children have these terminal conditions as well. And so Evelyn's House has that very specialized wing. But so inpatient hospice is what you do in the hospital. It's sometimes called GIP. But you must meet specific requirements. Like I said, like you cannot transport out. And there are specific medical interventions that you need that you cannot get at a facility or at your home. So for example, like you need a specific pump for pain management, or that being said, sometimes people are like, well, what if I'm on dialysis and I need to go on hospice? How does that work? Because dialysis is usually meant to be a life-sustaining treatment. And so sometimes if you're either at hospice at home or an inpatient hospice, what they might do is they might try to wean you off, because the goal is for comfort care. So you don't want to just abruptly stop a treatment such as dialysis, or if you have anything similar. So that's when you might be on inpatient hospice, because they're trying to wean you down to make sure you're comfortable and stable, because that's the whole goal of hospice, is to be comfortable. And then speaking of comfort, as we go to our next slide, DNR comfort, what does that mean? That's so DNR is do not resuscitate. That's what that acronym stands for. DNR comfort is another form of inpatient hospice, or sometimes the words are used interchangeably, inpatient hospice or DNR comfort. But this means you are in the hospital and or at a facility and all aggressive treatments are stopped. And you're only getting comfort medication. So you're only getting medications for like anxiety to help you sleep. You're only getting pain medication, anything like that. We deal with this at the hospital quite frequently, because I do have some patients that they're not able to leave the hospital. So we have to get them set up for either the inpatient hospice or put them on what's called comfort care or DNR comfort. There's kind of several different words you can use. And why we do it is to help make sure that they get that time to just be with their families, and just focus on what they want, which is being comfortable. And sometimes that looks different to different people. Some people want music, some people want all their family around. I had one family, this is when I was a chaplain resident, where the family was hovering and they were like brushing their mom's hair. They were making sure that she was comforted, and they were giving her sponge baths. They were showering her with love and affection. And they were told by some family friends, you may want to give her a little space. Not that the comfort and the love isn't helpful, but this patient was not very lovey in their life. And so they asked me what I thought, and I'm a firm believer that if a person is stubborn in life, they will be stubborn in death, however that looks to that person. But the minute that family left, this patient took her last breath. She was like, I am done. And it wasn't even 5 minutes. Like literally they were at the elevator and they decided, you know what, if that's how she wanted to be on her own. She wanted her own space. That's how she saw comfort at the end of her life, is being in her own space. We're just not going to come back. And they did. They went home and they called the funeral home and they did all that stuff. But I'll never forget that. It's a very firm, like I am very good example of people will do what they want. Death looks different to everybody. I had one patient that they were waiting and waiting and waiting because they had one child who lived out of state, and they were waiting for that person to come and see them. Eventually the person did come, but it was like the minute they walked into the hospital room, they took their last breath. So again, these are some things to think about when you're thinking about your end of life care or end of life choices. What is important to you? And it's something to tell your family. Do you want to be showered with love and affection? Would that be comfortable to you? Or do you want to be like, okay, everybody come say goodbye to me and then leave? Or do you want a mix of both? Maybe you want to balance that out. Or do you want music played? Do you want essential oils? Do you want flowers? Do you want what would you like? I know one colleague of mine, he helped pre-plan a funeral for somebody, one of his parishioners. This is when he was a pastor, and the parishioner said, I would like to have a funeral. Instead of a funeral, he wants a funeral. So this gentleman has written down everything he wants to happen, and it's when he goes on hospice care, because he would like to sign up for hospice. He has a chronic medical condition, and whenever he does make the transition from palliative to hospice, he would like to have his funeral ahead of time so that he can attend. It's going to be and he says a funeral, because he wants everybody to just have fun, have a dinner, have this gathering, and then that's it. I know. Amanda's face kind of says it all. Like, yeah, I know. It's different. You don't really think about it, but that's what's important to him, is to see his family together and to be a part of it. That's so to him, that's what brings him comfort.
Yeah. And it really is something important to think about, you know, because it looks a little different for everybody, just like you were saying, you know. And I really do think people wait for the moment that is right for them, you know. That my mom will still say she feels so bad because she had left. My grandfather ended up in Evelyn's house, actually, at the very end of his life, and she had left to get a change of clothes and was just going right back. And it probably took 45 minutes, and he passed while she was gone. And she still says, you know, I should have been there. And I've said to her before, maybe, you know, maybe he didn't want you there. Maybe he didn't, you know, maybe he just wanted to pass on his own and didn't necessarily want you to see that. So I don't know. It really is. It's a hard time for everyone, and just it's important to remember to be patient with yourself, to be patient with, yes, I mean, if you are the person who is passing, be patient with yourself, but more so if you're a loved one of someone who is passing, just be patient. Be patient with yourself and everything you're going through, and be patient with everybody around you, because everybody deals with grief differently. So yeah.
Well, no, it's exactly right. And whether you're the person thinking about your end of life care, or you're the loved one who's helping your family navigate this, or if it is just, say, a chronic condition. And again, I'm using MS as an example, but you can also think of like Parkinson's disease, or anything in that category, right? You know, these are some conversations you have to think about, or even if you don't have a chronic condition, but it's something to have a conversation with your family about, and to weigh out the benefits, which is kind of on the next slide. And Amanda has already touched on the benefits of having palliative care or hospice, whether you're at home, in a facility, or in the hospital, is you get what's called the multidisciplinary team. You get everybody and anybody under the sun of that medical team who will be helping you. As I said, you get the doctor who will supervise your care. You get the nurses and the nursing assistants who will help do the symptom pain management, offer guidance and education, as Amanda pointed out with her grandfather in that example, right? That is a good example of education that they offer, because they're trying to help. Because I'm sure doing an enema as often as he was doing that was probably an infection risk.
Yeah, it was not good. And she had to be pretty stern with him. She was like, look, Don, we gotta quit it.
But they'll do things like that. They will help navigate some of those things and help provide that education in a way that the families can't, because, you know, we can talk until we're blue in the face, but that doesn't mean our loved ones can listen to us. The other really good benefit is you will have a social worker and a chaplain. They will provide the social emotional support and coordinate additional services. Like I said, you know, you have some hospice companies that do massage therapy. Some hospice companies do music therapy. Some do both. Some will help you with advanced directives if you've not had one done and you really need to get one done, or maybe they'll refer you to wonderful elder and estate planning attorneys, which is on my next slide, which is part of this whole series, right? Is the importance of planning. When you're planning these things and you're asking these questions about, well, not only do I need to get my finances ordered, not only do I need to figure out what do I want medically, you do have to consider, what do I want at end of life? Do I want a funeral? Do I want how do I want to be cremated? You have to talk about all of this, and as well as plan for all of this, and make sure you are protected in that way. it's not just about protecting your assets and your legacy, it's actually protecting about your values and your viewpoint. And nobody really wants to talk about this stuff. Everybody gets really freaked out when they're like, well, I don't want to talk about my funeral because I have some family members that this is what they say. They say, well, I'll be dead. It's not my problem at that point. Well, but it is, it is a problem though. Because then if you don't plan it ahead of time, then nobody knows what you want. And that can lead to fighting. That can lead to financial stress for your loved ones. So it is important to have these discussions. For example, I hope my family has heard me say, because I've said it several times, I'm interested in it's called a green burial. So there's different ways to do it. I would really like to do what's called the biodegradable urn, where you ship my cremains off to this company. They package me and my cremains into a urn that then you plant the urn, and along with my cremains and the fertilizer and the urn itself, it becomes a plant. You can pick whatever plant you want. You can come back to life as a rose bush if you want, or a tree or something. But there's also different ways of doing you can get specialized caskets that are green burials that then the caskets will degrade along with your body. So then again, you become part of the fertilization. My husband also has said that he would like a Viking burial. That is really hard to figure out how to do. But things like that, and to have that conversation, because, well, I know what's important to him now, right? He wants the show and the tribute to his ancestry, that kind of stuff.
We hear that all the time. We hear, I don't care. I won't be around for it. It's like, well, if you're not going to choose, who would you like to choose? Because you're dumping this decision on somebody, and you are the best person to make the decision for yourself. So I always get frustrated with that. I'm like, but if you don't know, who does know, But, and then we have some clients who will go back and forth, and it'll be like, oh, I think I want to be buried. And then it's like, oh, no, maybe I want to be cremated. And that's perfectly fine. I have thought different things through my life, I would want to be, in the cemetery where my family is, or maybe not, you know. But the most important part of that is let your loved ones know, and whether you do that whether you write it down somewhere, whether you tell them verbally, whether you plan it out, so actually have a prepaid funeral of some sort. The how does not matter as much as doing it,
Right. It's the conversation itself, because there's so many factors to consider. And that's what on the next couple of slides, we're going to go through things to think about when you're having this conversation, because it's not necessarily just about funeral planning. And I will give an example. I called her my second mom. She was a really lifelong friend of my parents. And when she was put on hospice, she told her daughter that she didn't want a funeral. She has friends and family members from all over the country, all over the world. She did not want them to take time out of their busy schedules to come say goodbye to her. So there was no funeral. There was nothing. So sometimes it's just like, what happened? Like, it's just like, there was no other way for us to express our grief. So that's what funerals are. So it's not just, I won't be here, so I don't care. But it's not, funerals at that point are not about you. They're about everybody you love and their opportunity to grieve. So you have to think about that perspective too. And as we move on, when you're thinking about your end of life care and things you may want, we're going to talk about a few things. First up is CPR. I'm sure everybody has seen it in a movie or on a TV show. It is not as beautiful as they make it seem in the cinematic pictures. CPR in itself is actually quite harmful. If it is done properly, you will be breaking ribs. So think about this. If you or your loved one is in their 80s, say you're frail, and your heart stops, do you want CPR? Do you want to be resuscitated if you're going to end up with some cracked ribs? CPR is actually quite violent. It is supposed to be meant for like somebody of health, like of full health, like say a football player, like there was a football player, right? He passed out in the middle of the field and they rushed out and they gave him CPR and he recovered almost immediately. He's the prime example of who CPR is meant for. That being said, a lot of people have this misconception that they're going to get CPR and it's going to save their life. It's going to magically make them better. That's not the case. On the next slide, you'll actually see some statistics. So adults who get CPR in the hospital, if they have a serious illness, only 15 out of 100 leave the hospital and may live an average of 4 months. If you get CPR, like say you pass out in a park and somebody starts administering CPR to you, only 5 out of 100 will leave the hospital and potentially live up to a year. Versus if you're living at a facility, so think like a nursing home, and you end up getting CPR, only 2 out of 100 will potentially live up to a year after leaving the hospital. So while everybody thinks CPR is this magical save-all, and again, thanks to movie magic and all these things, it's really kind of dangerous. I mean, again, you break ribs, potentially those ribs puncture your lungs, and it's a really difficult recovery because your heart has stopped. That's why they're doing CPR to begin with. So you have to think, is that even worth it? Do I want to go through all that physical pain? And then on the next, and then here's some questions on this slide to kind of think about. If you attempt CPR, if you don't want to attempt CPR, and at the very bottom, it has your values. So if you would prefer a natural death, like say you don't want to put all your body on that, then you should probably sign what's called a DNR. Or talk to your doctors, like say you go into a hospital admission and you're going to get a hip replacement and you're like, well, you know what, if my heart stops while I'm here in the hospital, I don't want to deal with CPR. I don't want to deal with any of this stuff. You'll ask them to sign up a DNR, a do not resuscitate. And then ideally, they will then follow the procedure that if your heart stops, they will not do CPR or they will not intubate you either. However, but if you want to fight, if that's what's important to you, is to make sure you do everything and anything you can for your life, even with knowing that some of those statistics, I mean, I don't have all of them, but then you will need to let your medical team know that as well, especially your families too. If that's what's important to you when you're creating your legal documents or you're having this conversation with your families or your caregivers, you need to let them know what's important to you. Would you like to have CPR or would you not like to have CPR?
I just wanted to pop in here too and talk a little bit about CPR and the documents that we'd spoken about previously. So our second presentation was on 5 legal documents everyone needs to have. In there, we talked about the living will and we talked about advanced healthcare directives as well. Neither of those documents, though, are a DNR. And they're very helpful because they get you sort of thinking in this headspace of, okay, if 2 doctors have examined me and they've determined that there is no hope. So if I'm in a coma or if I'm at the very end stages of a terminal disease, would I want to remain artificially alive? So it's a little bit different of a conversation than CPR, but it's similar in that, it's kind of getting you thinking about, where do I draw that line? Do I want to be kept alive, regardless of any sort of pain that might come my way, regardless of, any other circumstances? And for some people, the answer is yes, and that's perfectly fine. For the vast majority of people, the answer is no. I would say of all the living wills I have seen signed or not signed, explained, I should say, I'd say 97% of people sign and say, remove the artificial support if I'm at that point. Now, the Advanced Healthcare Directive, like we talked about before, that allows your power of attorney to remove some different sorts of supports if you're in that situation. So the Advanced Healthcare Directive only applies when you're at that two physicians have personally examined you, you're at the end stages of a terminal disease, you're in a coma, something like that. And there are a bunch of different types of supports listed there, like artificial hydration, and CPR is one of the items listed. But the thing you need to keep in mind there is that you need that advanced directive present with you. You need to have shown it to the medical staff. And what I think a lot of times is a consideration as well is if you're in a facility or if you're at home and an ambulance comes or emergency personnel need to be called, they will resuscitate you regardless of what that living will, that advanced directive says. If you do want a DNR like that in place, so if you want not to have CPR, let's say you're at home and you're on hospice, you don't want CPR. What you need is, it's called a TPOP form, TPOPP, or PULSed is another acronym that's used for it. A lot of people know it as like the purple sheet. And it's a form that they've recently updated, actually. I think they did it in late 24. But you go over it with your doctor, and it is designed to be a true DNR. And then keep it somewhere of prominence, right? Because the other thing is, emergency responders are trained to resuscitate, right? And because of liability reasons, they will, unless there is clear and absolute instruction otherwise. And those forms are provided by the state of Missouri. They're not produced by attorneys, so you wouldn't need an attorney to provide that form for you, but you do need your doctor to sign off. So it is one of those things that, and understand, oh, is that ringing out loud? Hold on, 1 second. Sorry about that, everyone. What was I saying? TPOP pulse forms. It is a form that you'll go over with your doctor. So don't be intimidated if you look it up and you say, I don't know exactly how to fill this out, or I don't know exactly what they mean. Because you'll go over it with your doctor. And sort of it helps you to strategize all these things that we've been talking about. And make sure that you can make your wishes very apparent if you're in that situation. Does that sort of clarify, Lee?
No, I think what's funny about this too is because that helps a lot, especially when you're talking about pulse documents, because that's a newer thing in Missouri. They've had them in other states, but in Missouri itself, they're kind of newer. But in the hospital, and this is something that people may not realize, your chaplains are the ones that are presenting the advanced directives to you. So if you're in the hospital and you're like, I really need to fill out that advanced directive paperwork, they will send your chaplain to you. And I think it's because we ask a lot of these difficult questions, like when you are in that worst case scenario of, if you're watching Grey's Anatomy, right? They say, oh, this person's brain dead, right? We're the ones that probably know how to navigate that conversation, because there is a spiritual component to it as well. Like I know some faith traditions, they don't want blood transfusions, right? If you're a Jehovah's Witness, you don't want blood transfusions, even if it's the last case scenario. There's a spiritual and religious reason for that. And then other people, they will stop everything, but they still want to get feeding and water. They still want that artificial hydration. They want the option to have food. That's what's really important to them spiritually. And so we're there to help navigate that conversation. It's kind of funny because a very long time ago, I also used to work for Eamon Gantner and Capriano, and I would help people fill out their Medicaid and VA applications. I never thought it would come in handy as a chaplain, but it does. but
Lee, last rites is another great example there.
yes,
We have lots of clients who add that into their advanced directives because it's important to them. And in the Catholic faith, you know, it's a sacrament you can receive at the end of your life. And stuff like that. It's tell someone that you want it,
right.
you know.
Well, and fun fact, it's not called last rites. It's
Okay.
um it's a common misconception because it used to be called last rites like many, many long time ago. And then after Vatican II, they changed it to be called the anointing of the sick because it's not just for people at end of life at death's door. Say you're just going to the hospital and you're getting a knee replacement. You're going to get this knee replacement and go back and go home. But if you're sick and you want to be healed spiritually and sacramentally, you can ask for an anointing.
That is
Last
very
rites
interesting.
is a very old term for it.
It's good to know. They're still
So
teaching that in Catholic school.
they are, and they shouldn't be.
We gotta let them know that.
I actually, one of our chaplain residents last year, her name, well, not her name, but she was big on learning the sacraments, and she was very clear that technically what it's supposed to be called is viaticum. And I didn't know that. I had, because I'm not Catholic, right? I'm, I'm actually Protestant. But she was very clear and she was very educational on making sure that I knew that for any of my patients that ask for last rites, they need to clarify, well, do they want anointing or do they want viaticum? Because viaticum is when you get your like when you get your last communion. That's what makes it last rites, put it into quotes, right? Is when you get the very last time you get the Eucharist.
Interesting.
Mm-hmm.
See, we're learning all kinds of things here today.
You know what? I didn't know that either. I had no idea until she taught me because I knew about the last rites thing, that was pre-Vatican II. That's what it was called, last rites. And then after Vatican II, they're like, well, technically it's a sacrament of healing. Right. So they changed the name.
Huh. That's good to know. Very good to know.
And speaking of, you did bring up for some people, right, eating is important, right, spiritually. So that's where feeding tubes comes into play. And why I wanted to talk about it, because some people are really adamant on, well, if I just can eat, then I will get better, right? If I get that nutrition, I will get better. Well, that's not always the case, because sometimes you can eat and then it becomes a choking risk, and then you can then aspirate and choke and still end up dying because you're trying to force your body to do something that it's not wanting to do. And that's what this very next slide tells some statistics about long-term feeding tubes and the decision to get feeding tubes, right? So if your values are to, at the bottom of this again, and these are from Respecting Choices, I'm sure you can find them online. I had a colleague who at a previous hospital he worked at, they would hand these out to patients. And I'm like, these are very helpful. But if your goal is that you think feeding will help you live longer and that you're willing to kind of navigate that discomfort, then chances are feeding tubes are the right avenue for you. But if you're wanting some time to make a decision, if you're like, well, I just want to see how it goes, then you can get a short term, like a trial tube feeding and see how it goes, see how you feel. Or if you're just like, you know what, I'm done with this, I'm at the end of my life, I don't really care anymore, then you can eat and drink for pleasure. You know, when we have patients that are on hospice and their families are like, they're just demanding a cheeseburger. Well, go get them the cheeseburger. Get them their favorite cheeseburger from their favorite restaurant. Like at that point, it doesn't really matter.
We have a client whose wife actually had a brain aneurysm, and she has a trach and a feeding tube, and she is always gesturing to her husband because he'll come in with a soda or he'll come in with his meal and eat with her, and she always wants it. And he says it's terrible because he's like, she loved to eat and she loved the experience of eating, and she can't get that anymore, you know. And she pulls her feeding tube out sometimes too, which I think is her indicating in her own way. that maybe, if things had gone differently, I'm not sure if it would have been her choice. And the other thing to keep in mind here is, unfortunately, once certain aids are put in place, it's much more difficult to have them removed.
Right.
And that just goes back to the importance of planning at large, right? And making sure your loved ones know what you want, because you might not be in the position to voice those desires, but someone else, your loved one, can. And Lee, I'm not sure if maybe you can speak to that a little bit more, but I know in their situation, it obviously he does not want to remove the nutritional support. I think in a lot of ways she's indicating that she would want it removed, and she did have advanced directives in place. She had a living will, she had advanced directives. He had power of attorney, and I know when some of these things were asked to him, what do we do? He answered, and I think it's very difficult, and it's one of the reasons that choosing a healthcare power of attorney is so important, because you want them to make the decision that you would want made, not the decision that they might make when they're faced with all of this overwhelming, something happening to their person, right? They might not make the decision that in their rational state, they would know that you would want to be made.
Well, and we deal with this quite a bit in the hospital, especially, and again, with feeding tubes, and is one of them to think about, or NG tubes. Those are the things that they go up your nose and they go down into your throat. Especially if you say you're a caregiver for somebody who has dementia, they signed these advanced directives years and years ago, and now you're suddenly dealing with their memory loss, and they get that NG tube and they pull it out. And I am shocked every time I see a patient do it. I'm like, how is that? But that to me is a clear indicator that they're done with this, right? That they, you may not verbally be able to express it, but you can sure tell people when you're done, because that's uncomfortable. Same with breathing machines and ventilators and things, which is actually the next slide, ventilators, right? So there's different kinds of ventilators. You have just the nasal cannula, which is those little tubes that just go in your nose and it wraps around, or you have a BiPAP, which is just these big nasal things, and it's just like right there and it's focused pressure in your face. Or you have tubes and you're intubated, or you get the trach. These are things these are uncomfortable. And once you get a trach, it's a pretty much a long-term decision. You can get some temporary ones, but it's ultimately, majority of the time, it's a long-term choice. And if you don't want to live with something in your throat, and basically you will be then on a ventilator for your entire life, they just hook it up here on your throat instead of like in your mouth, you need to tell somebody now. You need to write that out. And as Amanda pointed out, you also need to make sure when you're signing those advanced directives, and when I talk to patients in the hospital, I tell them all the time, you need to make sure that it is somebody who will actually follow through with what you have written. Because in that turn of the moment, like I had a patient, and I still think about this all the time. It was in the height of COVID. The patient years before had made their child their POA. And then suddenly COVID came out, and the patient got a pneumonia and was dealing with all these things, as well as some other chronic health conditions. And their child was trying to come in and make all these decisions. And the patient's like, I don't want you to make my decisions anymore because you're not getting a vaccine, because didn't want to get the COVID vaccine. And it's like, if you are not listening to the medical professionals and getting a vaccine and making that decision for yourself, I don't trust you to make decisions for myself. And that was just their family dynamic, right? I know a lot of people have different viewpoints on this, but essentially because of that disagreement they were having, the patient wanted to switch. And we did everything we could to make sure that could happen. However, they got so ill that they couldn't sign and get it notarized before their end of life care. And you're like, oh no, I think about them all the time and how bad I felt, because that patient had a clear viewpoint that they did not want the vent, they did not want the feeding tube, they did not want these things. and they'd had this discussion multiple times with their family member. And suddenly over this big disagreement that was coming out, they no longer trusted the child to make that decision. And I see that I had that at the hospital a few months ago, that the patient had a DNR. They even had the DNR bracelet on their hand. They signed the pulse document. They were like, don't want that. And then suddenly the question came up because the patient started to have trouble breathing. And so they're like, well, do we intubate the patient? Do we put them on the medical ventilator then? Because they don't want the DNR, but is that a DNI? Do they also not want to be intubated? Do they not want that extra support? Because usually they go hand in hand. Sometimes they don't, but usually they go hand in hand. That if you don't want to be resuscitated, you don't want to be on a ventilator. Some people don't mind. Some people say, well, yeah, sure, you can give me, I don't want the CPR, but if you can give me a tube temporarily, sure, I'll be intubated temporarily. I'll be on the ventilator for a short term. Well, so they started doing CPR on this patient until they could get an answer from the family. Well, then the family came back and said, you do everything you want for our loved one because we don't care what they signed. We want them to live, which is a huge red flag. So eventually, when the patient did recover, we encouraged them to please talk with your family because clearly there's some miscommunications here, that this is your value. You had the purple bracelet. You had all the stuffs ready to go, but your family was very vehement and very adamant that they were not going to listen to that they wanted you to live.
Unfortunately, there we go. Unfortunately, in sort of the legal arena, I think you see it in hospitals, you see it in the court systems. We lean toward keep the person alive, right? Which is understandable because it's not a reversible decision once made. But when people become very agitated like that, it's very understandable for doctors and nurses and people to give those forms of support to the patient and so that's why you want these documents to be as ironclad as possible, and that's why you want to have those really difficult conversations with your family members, with whoever might be there at the time. Leah, I wanted to ask you, do you have any idea and I know this is a weird question because it's going to be a statistic, but just from your experience, of the people who are put on a ventilator or are intubated, how many people end up coming off? Oh, hold on, you're muted.
It did not unmute even though I hit the thing. So that's actually my next slide, is if you had any questions. So, and the answer is it kind of depends on what their diagnosis is. I know during COVID, it was like 80% that if you were in the hospital with COVID and you got put on a vent, the chances were you were never coming off. Like it was 80% was never going to survive afterwards. You can go on a vent for a lot of things. Like you can sometimes after a cardiac procedure, like if you're getting a heart procedure done, they will temporarily put you on a vent to give your heart a chance to heal before taking you off. Right? So statistically in those cases, you're probably going to come off the vent pretty easily. Or like I just had a procedure done where they intubated me because I was getting a sinus procedure. Well, so because they were up in my nose, they had to intubate me because they had to make sure I could breathe while they were up inside my sinus cavities. I mean, I obviously came off the very same day. Or like if you get pneumonia, the chances are if you have a pneumonia, you're maybe not going to come off the vent. So that's why it's hard to say statistically too. Yeah. But that is, again, if you're thinking about this as I'm planning my end of life care, I'm trying to protect my legacy, my well-being, my person, my values, from a spiritual and social perspective, you have to think about these other statistics as well, or think about these other possibilities. Like, well, what if I get pneumonia? Do I want to get put on a vent if it's statistically unlikely that I won't come off the vent? Like, these are questions for your doctor actually to be involved in your discussion. So to talk about them, like, because they know those statistics better than I do.
Well, and I would
Oh.
have to imagine, just because of the reality of things, that as you get older, your body is less able to, once put on a vent, to come off, right?
Right.
So if we're thinking about this in the sort of like hospice, palliative care, as sort of end of life arena, I would have to think that your odds of coming off of the vent, if you're put on the vent, go down pretty dramatically.
They do, because it's harder for your body to recover from that too. And you have to think too, like if you have, say, a chronic cancer condition, like my husband, he had a high school friend, they had their child was born around the same time as our child. I think there's a 6 months age difference, but their child immediately got diagnosed with leukemia. And after months and months and months and months and months of battling the leukemia, they had to make this difficult decision with their 4-year-old and put the 4-year-old on hospice. You know, you don't want to think of, I mean, because end of life can happen at any point, but they, as a family, had to sit down and figure out what was important to them, including this 4-year-old, and have this discussion of, well, if we get to a certain point, does the 4-year-old want to be on a vent? Did the 4-year-old want CPR? Did you know, did the 4-year-old want a feeding tube? And that's why they ended up putting the poor thing on hospice, and he did end up passing away. And it's just very sad to think about, you know. If it's important at no matter what age to have these discussions with your family. That's part of why, like, they say to know what you want, what your values are. That's a big consideration, right? Again, for our, if you're Catholic and you're like, I want this anointing of the sick, I want those last rites, that's important to me. Or if you're a Jehovah's Witness and you're like, I do not in any way, shape, or form want to be put, I do not want a blood transfusion, or, you know, whatever it may be. I've had some patients where they really want to get their healthcare directives done in the hospital because they had to leave an abusive partner, and they're still technically married to this abusive partner, but they have a new spouse. So they have to navigate that too. Like, there's a lot of complex decisions when it comes to this kind of stuff, and that you have to consider, like, well, do I want that person involved? No.
Right.
Unfortunately, given the time, I do have to leave it a little bit.
No, I think this is wonderful. Did we
but
get
if
any questions on Facebook? I'm not sure.
I didn't see any, but if there are
Okay.
any, I can follow up and make sure.
Absolutely. Well, and then next we are looking at November 3rd. That is going to be next Monday. And we will be talking about community resources and supports. So I know throughout these series we've talked about, there are a whole host of professional individuals out there who can help you navigate all of this stuff. And so, Gail and I really just want to give you, here are some of the community resources out there. Here are some of the supports to look into. So that's what we're going to be doing next week. And then our last session will be next Wednesday, and it's pulling it all together. So we'll kind of just brief overview of everything we've gone over. And thanks so much to Lee for coming and talking to us today about hospice and end of life. I think it was super useful, and fit right into all of our other discussions. So we really appreciate it.
Well, thank you for having me. As it was said earlier, you know, I am on the board for Aging Advantage, and I kind of help do some of the social media and kind of behind the scenes things, but I am also chaplain, and so this is my wheelhouse is I help people make these decisions. So if you're in a situation and you're like, I need to make some of these decisions, and you're in the hospital, reach out to your chaplain. They'll be able to help you navigate some of that.
There you go. All right. Well, we will see everybody.
And the chaplains do also have perspectives from other traditions, not just Christian. So like fun fact, there's actually at Harvard, I believe, it's Harvard, it's some, or Princeton, it's one of the Ivy League schools on the East Coast, has an atheist chaplain.
Oh, that's interesting.
So because chaplains deal with more than just spiritual perspectives of their own faith tradition, we're trained in other things. So like I had a colleague who won an award in our hospital system for helping a Hindu family do their end of life ritual as their patient died as their loved one died in the emergency room.
Do you have chaplains, Lee, that focus, like, concentrate, like, do you tend to help patients who are Christian, or is it
I
sort
help
of
everybody.
anybody? Okay.
Mhm.
And then are most of the chaplains that you work with kind of come from different faiths, different backgrounds, or
Yep.
yeah.
We all come from different backgrounds. However, I am at a Catholic hospital system, so most of the other chaplains are Catholic or have some Catholic perspective. Like one of my colleagues they grew up Catholic. They sometimes attend Catholic church, but most of their faith tradition now is mostly personal, one-on-one. They go on bike rides. That's their churches. They go on a bike ride every Sunday. That kind of stuff, you know.
Yeah.
I also work with a Catholic priest. I work with a spiritualist chaplain who at one point was a Presbyterian pastor. We're all from different perspectives and backgrounds. I also know of a Buddhist chaplain in my hospital system. There was a Jewish chaplain. However, now she has since moved to a new city, and I'm very sad because she was great. So we're from all different faith traditions, and we all get trained culturally and spiritually to address different concerns across the board. I actually also specialize in the mother baby units, so that's kind of my thing.
Oh, cool. That's just so cool.
That being said, I have to go to a Halloween party. So thank you for having me. It was nice to interact with you all, and please let us know if you have any other questions or concerns.
That's right. And if not, we will see you on Monday.